Hi, I'm Ken Kester. I'm the pharmacy team leader at Nebraska Heart Hospital. I'm here to talk to you about cardiology medications, new drugs, and new guidelines. Our objectives are to understand indications, side effects, and monitoring parameters for newer antiplatelet medications, indications, side effects, and monitoring parameters for newer anticoagulant medications, recent changes in guidelines for management of high blood pressure, and recent changes in guidelines for the treatment of blood cholesterol to reduce atherosclerotic cardiovascular risk, which is fun to say fast. Disclosures, I have no disclosures. I've never had a disclosure in my life. For a brief introduction, there are some new medications for treatment of cardiology patients. Some of these meds can be used for non-cardiology purposes as well, but I'll be focusing on cardiology purposes. Lately, there were two new antiplatelet medications, prasugrel and ticagrelor. They go along with clopidogrel, the one that's been around for a while. Also, there are three new anticoagulants. Forever, all we had was warfarin or Coumadin. Now we also have dabigatran, rivaroxaban, and apixaban. And all of these drugs came out at about the same time. So I thought it would be nice to go through them here together. The second half of the presentation, we'll go through some new guidelines that came out late last year, late 2013. One is the new guidelines on hypertension. The other is the new guidelines on lipid control. So those are four discrete topics we're going to cover in about 45 minutes to an hour. And we'll start in with the antiplatelet medications. The new ones are prasugrel and ticagrelor, or Effient and Brilinta. The old one is clopidogrel or Plavix, but you can't really talk about the second two without talking about the first one, clopidogrel. By the way, when we talk about the new drugs, I'm going to list them in order of when they were released. It's not alphabetical or anything, it's just when they came out. So what these drugs have in common is their mechanism of action. They all bind and antagonize the platelet P2Y12 receptor, which prevents ADP binding. With ADP unable to bind to the platelet, activation of glycoprotein 2B3A complex is impaired. Because that complex is the major platelet receptor for fibrinogen, fibrinogen binding and ultimately platelet aggregation is also impaired. Now, on the next slide, you see this nice little chart. If you read the bottom, you can tell I got this from some German website, apparently. And it refers to clopidogrel, mode of action of clopidogrel, but this same mode of action applies to prasugrel and ticagrelor. If you see on the top there that little C thing, that represents clopidogrel blocking an ADP receptor. What's supposed to happen is ADP gets into that receptor and activates the glycoprotein 2B3A receptor, enabling it to accept fibrinogen, and that starts the whole platelet aggregation thing off. So when that receptor is blocked by one of these three drugs, ADP is not able to activate that receptor, therefore diminishing the activity of the glycoprotein 2B3A receptor. That inhibits the activity of that receptor. And if you look on this slide also, you can see the different places that other drugs work. There at the bottom, aspirin works by inhibiting thromboxane, and of course the glycoprotein 2B3A inhibitors, those are the newer IV inhibitors, tarafiban, abciximab, and eptifibatide, they go into that receptor. But there are sort of three different ways that these drugs can block that activity. That's why we often use all three of them together in the cath lab, and after the cath lab, we'll give a clopidogrel, one of these three drugs, clopidogrel, prasugrel, or ticagrelor, along with aspirin, because they have different mechanisms of action. The first drug we'll talk about now is clopidogrel. Clopidogrel has the most indications. It's been around the longest. It's used for acute myocardial infarction, arterial thromboembolism prophylaxis, myocardial infarction prophylaxis, percutaneous coronary intervention, or PCI, stroke prophylaxis, thrombosis prophylaxis, transient ischemic attack, or TIA, and unstable angina. The dose, first of all, for use in PCI and some other uses also, you use a loading dose, and that's usually 300 to 600 milligrams. Maintenance dose is then 75 milligrams daily. We do not need to adjust the dose of clopidogrel for renal impairment. Adverse effects, bleeding. I mean, all of these drugs, that's the big adverse effect, is bleeding. Two of them, as we consider these different antiplatelet and anticoagulants, have some other side effects to think about, but the predominant thing we worry about is bleeding. For monitoring, well, we monitor for bleeding, we monitor complete blood cell counts, and we monitor LFTs, liver function tests as well, with clopidogrel. The first drug to join clopidogrel was prasugrel, or Effient. Prasugrel is indicated for use in acute myocardial infarction, arterial thromboembolism prophylaxis, percutaneous coronary intervention, and unstable angina. The loading dose for prasugrel, when a loading dose is indicated, is 60 milligrams. Maintenance dose is 10 milligrams daily, although we'll drop that dose down to 5 milligrams in patients weighing less than 60 kilograms. Its use is not recommended for patients over 75, but when it's used in those patients, that should also be the 5 milligram dose. No adjustments necessary for renal impairment. Adverse effects, once again, bleeding, and for monitoring, we look for bleeding, look for complete blood cell counts. Ticagrelor is the third one and the most recently released one. Ticagrelor is indicated for use in acute MI, arterial thromboembolism prophylaxis, PCI, and unstable angina. Loading dose of ticagrelor is 180 milligrams, and then the maintenance dose is 90 milligrams twice a day. No adjustment for renal impairment. Side effects, once again, bleeding. Also a side effect of ticagrelor that's seen pretty frequently is dyspnea. People have a little trouble breathing, feel wheezy. About 10% of patients may experience this. Generally speaking, you can go on with therapy. In the studies to get this drug on the market, a little bit less than 1% of patients had to stop treatment because of this side effect. But generally speaking, you keep it going and eventually the wheezing seems to kind of go away. We monitor for bleeding, we monitor complete blood cell counts, and also LFTs with this drug. One thing to consider with all of these drugs is we give them in the cath lab, but they're indicated for PCI among other uses. But sometimes they go in the cath lab and you figure out we got to take this guy to surgery, but they've already received the drug. And then the question is, how long do we have to wait to do surgery? Well, for clopidogrel and ticagrelor, you should wait at least 5 days to do surgery if you can. That is for elective surgery. For prasugrel, you're supposed to wait 7 days after the last dose before doing elective surgery. So what's similar about these medications? Well, they have similar mechanisms of action. They also have pretty similar indications. Clopidogrel has a bit more, but we think of using them predominantly for acute coronary syndrome and for PCI. What's different about these medications? Well, their pharmacokinetics are different. Clopidogrel's onset of action is about 2 hours. The other two have an onset of action within about 30 minutes. Binding to the receptor site is a little different too. Clopidogrel and prasugrel both bind irreversibly. That means when they bind into that receptor site, they don't let go. In order for platelet activity to return, your body has to regenerate new platelets. They'll stay in that receptor site until that platelet goes away. Therefore, they are irreversible binders, and that's why their duration of action is about 5 days. Ticagrelor is a reversible binder, and its duration of action is shorter. However, we're still supposed to wait 5 days after the last dose before we have surgery. The fact of the matter is, 2 days after the last dose of ticagrelor, they're about at the same point as far as platelet aggregation is concerned. They're about the same point as they are with clopidogrel after 5 days. So activity does return sooner with ticagrelor. Even so, the company recommends waiting 5 days for elective surgery. Some other things that are different. Clopidogrel is known to not work very well in poor metabolizers. Some patients just respond poorly to it. Unfortunately, we don't really know who these patients are going to be until it happens. There is a test to determine patients with a genetic predisposition to respond poorly, but that test is not widely available and most places don't use it. Contraindications are a little different too, in particular for prasugrel. Prasugrel is contraindicated in patients with a history of TIA or stroke. Those patients tended to bleed in studies when they got prasugrel. A few other things that are different. As far as efficacy is concerned, both prasugrel and ticagrelor have generally been shown to be a little more effective than clopidogrel. However, clopidogrel is a little less likely to cause bleeding. So they always weigh that efficacy versus safety when giving these drugs. The cost is also quite a bit different. Clopidogrel used to be quite expensive back when it was trade name Plavix. It's not anymore, it's generic now. And I've got these costs per month by average wholesale price. Average wholesale price, it's sort of like the manufacturer's suggested retail price. It's a price that's assigned to it. For clopidogrel, the average wholesale, and let me also say pharmacies a lot of times use average wholesale price as sort of a base to charge their customers. The average wholesale price of clopidogrel is about $20 a month, but for prasugrel, it's more like $320. Ticagrelor is about $300. So these are $10 a day drugs and more, so they're pretty expensive. That's one of the reasons we still see clopidogrel used quite a bit, even though it's widely thought the other two may be a little more effective. So that's it for antiplatelet medications. We'll move on now to the anticoagulant medications. First of all, we get to see the wonderful clotting cascade, everyone's favorite cascade. We'll just spend a few minutes on it, but it's instructive. First of all, it's just impressive to see a slide like this, right? But it's also instructive to see where the different drugs work in the clotting cascade. On the left side of the clotting cascade, you have the contact activation or intrinsic pathway. On the right side at the top, you have the tissue factor or extrinsic pathway. If you experience trauma, it's the right top side that kicks in. If you have some endogenous injury, then the left side or intrinsic pathway kicks in. But they all join together around prothrombin, which is activated to form thrombin. And then thrombin helps convert fibrinogen into fibrin. Fibrin is activated by factor 13 to start to form cross-linked fibrin clots, and it actually has a role also in platelet aggregation. Now, we think about the different antithrombotics or anticoagulants. There are several, and where they work, I mean, unfractionated heparin works on a bunch of different factors. Low molecular weight heparin works on factor 2A and 10A. Fondaparinux and two of the new ones, rivaroxaban and apixaban, work on 10A. Warfarin works on several. Argatroban, lepirudin, and bivalirudin work on 2A, and dabigatran, one of the new ones, works on 2A as well. If we look at the depiction here, here's where unfractionated heparin works, several different sites. Warfarin, 4 different sites. Enoxaparin works on a couple of different sites, thrombin and factor 10A. One of the new ones, dabigatran, as well as bivalirudin and lepirudin and argatroban, work on factor 2A or thrombin. And then rivaroxaban and apixaban, 2 of the new ones, along with fondaparinux, work on factor 10A. When we think about the new anticoagulants, it's helpful to first think about the old anticoagulant, and that's warfarin. Warfarin or Coumadin came out in 1954. One of the early people to get treated with this drug was Dwight Eisenhower. He had a heart attack when he was president, and they gave him Coumadin afterwards. Coumadin is a derivative of coumarin, which is found in some plants. In fact, the name warfarin comes from Wisconsin Alumni Research Foundation, plus ARIN, A-R-I-N, which denotes a coumarin. Why did Wisconsin get involved? Well, here's what happened. There was a plant called sweet clover. When sweet clover got rotten, cattle would eat it, and they would tend to bleed to death. And at some point, some farmer got tired of it. I guess he was a rancher, he had cattle, and he hauled the cow to the University of Wisconsin and said, why are my cattle bleeding to death? And they figured out that it's because of this compound coumarin that was in this rotting sweet clover. And from that, they ultimately developed warfarin. So there's your pharmacy trivia for today. Warfarin's mechanism of action is this, and it's a little bit complicated how this stuff works. The synthesis of factors 2, 7, 9, and 10 require vitamin K. Warfarin competitively inhibits an enzyme that activates vitamin K. This ends up depleting vitamin K reserves, which ultimately reduces the synthesis of clotting factors. But because the mechanism of action is a little bit convoluted, it takes a while to work. So the onset of action is pretty slow. And there are a lot of foods have vitamin K in it, so there are a lot of vitamin K-rich food interactions. Also, there are a whole bunch of drug interactions, more than I want to list here. Basically, it's metabolized via cytochrome P450 pathways. Many drugs enhance the activity of warfarin, many drugs diminish the activity of warfarin. When I'm counseling patients on warfarin, I don't tell them the drugs to look out for. I just tell them, always talk to a pharmacist if you're going to take this drug, if you're going to be put on other drugs, because they need to check everyone to see if they're going to interact, and if so, how they're going to interact. And again, vitamin K rich foods may diminish activity if people eat a lot of them in a short period of time. With warfarin, of course, we must monitor its activity, and we do that by measuring the INR, or International Normalized Ratio activity. The cost of doing INR measures are about $30 to $50 a month, so the drug's actually pretty cheap. The test costs more than the drug does. Patients generally will have tests done once a week or so for the first month or two until they get their dose stabilized. After that, it's usually about once a month. So, that was the only oral anticoagulant for decades, and I've been around a little while. I kept hearing year after year a new Coumadin is going to come out, but it never happened. Finally, it came true. Dabigatran was released probably 3 or 4 years ago. Dabigatran, or Pradaxa, it's a direct thrombin inhibitor, that is factor 2A. It inhibits both free and fibrin-bound thrombin, and it prevents thrombin-mediated effects, including cleavage of fibrinogen to form fibrin, activation of factors 5, 8, 11, and 13, and thrombin-induced platelet aggregation. And here's where it works. Indications for dabigatran are non-valvular atrial fibrillation. It's sometimes used for some other things, but that's the only FDA-approved indication. Dose is 150 milligrams twice a day, although we will drop that dose down in patients with impaired renal function. There is no antidote for dabigatran. As opposed to warfarin, we have the antidote phytonadione or vitamin K. Adverse effects, again, the main one we think about is bleeding. GI upset also happens quite often with dabigatran, and here's why. This drug needs to be in a very acidic environment to be absorbed. And if you get a dabigatran capsule, it's actually little beads in this capsule, and those beads are encapsulated by an acid compound. And one of the reasons for stomach upset may be when that stuff dissolves, it gives you a GI upset. And up to 11% of patients experience that, and a fair number of them stop therapy because of it. As far as monitoring, you should monitor renal function because it affects dosing. Other than that, partial thromboplastin time, or ECT, may be used to assess anticoagulant activity, but it's more a qualitative than quantitative measure. You can tell whether the drug's doing anything, but you don't adjust doses based on those levels, and they're not frequently drawn. Onset of action for dabigatran is about 2 hours, and the duration is 12 to 17 hours. That's a lot different than warfarin. Warfarin's onset is 2 or 3 days, and the duration after you stop it is probably 3 to 5 days. Metabolism, dabigatran, it goes like this. The prodrug, dabigatran etexylate, is hydrolyzed to form an active drug. That's then metabolized by hepatic conjugation. There's no CYP involvement, no cytochrome P450 involvement, which ultimately means you don't have nearly as many drug interactions as with warfarin. Renal excretion is up to 80%. As far as interactions are concerned, it's important to think about them because the drug we compare it to is warfarin, which has a whole bunch of interactions. Rifampin might decrease dabigatran activity and should be avoided. There may be interactions with amiodarone, dronedarone, ketoconazole, quinidine, and verapamil. They might increase dabigatran activity, so you need to be cautious with those, but they're not contraindicated. Routine labs are not required, but the cost is about $350 a month, average wholesale price. So again, this is at least a $10 a day drug. The next one that was released was rivaroxaban, or Xarelto. This is a factor 10A inhibitor. It prevents the formation of thrombin, or 2A, from prothrombin, or factor 2. So there's where it works. Rivaroxaban has a couple more indications than dabigatran. It's indicated for non-valvular atrial fib, DVT prophylaxis and treatment, including post-hip and knee replacement, and pulmonary embolism prophylaxis and treatment. The AFib dose is 20 milligrams daily. You drop that down to 15 if the creatinine clearance is from 15 to 50. Treatment of DVT and PE is 15 milligrams twice a day for 21 days, and then 20 milligrams daily. For DVT and PE prophylaxis, 20 milligrams, and for post-op hip and knee surgery, 10 milligrams daily. And the company markets it in an interesting way. All of these dosage forms cost exactly the same. So you might think, well, I'll buy the 20 milligram tablets and cut those in half. You can't really do that though, because the tablets are shaped funny and they're virtually impossible to cut precisely in half. So you're pretty much stuck with the price you get. Adverse effects, the main one we think about, of course, is bleeding. Once again, there's no antidote for this drug, like dabigatran. Time to peak is 2 to 4 hours. Half-life is 5 to 9 hours. Quite frankly, the peak and the half-life is very similar to dabigatran and apixaban, the next one we'll consider. Even so, rivaroxaban is dosed once a day. The other two are twice a day. Metabolism, some hepatic via CYP3A and CYP2J2, but a large amount of it is renally excreted, about 2/3 of it, and about 36% of that is unchanged. So the CYP3A4 inhibitors might enhance activity. These are drugs like ketoconazole, clarithromycin, and fluconazole. CP3A4 inducers might diminish activity, and that would be a drug like carbamazepine. Not contraindicated, just you need to be aware. Routine labs are not required. The cost is about $340 a month, AWP. All these new ones are about the same, cost-wise. Apixaban is the third one, or Eliquis, and that was the one that was most recently released. It's also a factor 10A inhibitor, which decreases adrenaline generation of thrombin. Indications are for stroke and systemic embolism prophylaxis in patients with non-valvular atrial fib, also DVT and PE prophylaxis in patients undergoing hip and knee surgery. The dose for AFib is 5 milligrams twice a day, but we do drop that dose down if they're 80 or older, or if they weigh 60 kilograms or less, or if their serum creatinine is 1.5 or more. For hip and knee replacement, the dose is 2.5 milligrams twice a day. Once again, the antidote is none. There is no antidote for apixaban. Main side effect we think about is bleeding, and for monitoring, routine labs are not required. Time to peak is 3 to 4 hours. Half-life is 12 hours. Metabolism, mostly hepatic via CYP3A4 activity, but about a third of it, or about a fourth of it actually, is renally excreted. CYP3A4 inhibitors may enhance activity. Again, that's ketoconazole, clarithromycin, and fluconazole, and inducers might diminish it, again, like carbamazepine. A lot of similarities between this drug and rivaroxaban. Cost is about $350 a month, AWP. So that's the 3 new ones and the old one. What's similar between these meds, between the 3 new meds? Well, they're all indicated for non-valvular atrial fibrillation. They're generally as effective or more effective than warfarin in preventing thrombosis. Unfortunately, they've never been compared together. They've been compared with warfarin. They're probably more effective than warfarin, and they're generally as safe or safer than warfarin in terms of bleeding incidents. Far fewer drug interactions than warfarin. No routine lab monitoring, no antidote. And that's the kind of icky thing about these drugs. With warfarin, there are 2 things that are a little bit funny. One is we don't like the fact that we have to do labs to dose it. On the other hand, when you don't have those labs, you sort of lose a security blanket, because if a patient's not taking warfarin, you find that out pretty quickly. If they're not taking one of these new drugs, you really don't know that. So we lose the lab security blanket. The other nice thing about warfarin is there is an antidote, vitamin K. We do not have an antidote for the other ones. You just have to treat the bleeding. Another point in terms of when can we perform elective surgery versus the last dose to receive of these new drugs. Because with vitamin K, with warfarin, we can give them some vitamin K. With these other drugs, we need to wait. With rivaroxaban, we should wait at least 24 hours. With apixaban, we should wait at least 48 hours. And with dabigatran, it depends. It's 24 to 48 hours, 3 to 5 days if their creatinine clearance is less than 50. So we don't have to wait as long as with the antiplatelet drugs, but we should still wait a bit. What's different about these meds? It's difficult to say because they haven't directly been compared. Indications, rivaroxaban has the most indications. Dabigatran has the fewest. It's really just FDA approved for non-valvular AFib. So now we'll move on to the hypertension guidelines. These come from this article. You can read the title. I won't. It's a mouthful. It was published in JAMA in December 2013. They're called the JNC8 guidelines, but they kind of aren't the JNC8 guidelines. They're a report from the panel members appointed to the 8th Joint National Committee. And here's the deal. Historically, the Joint National Committee issued guidelines sanctioned by NHLBI, or the National Heart, Lung, and Blood Institute. And they got this ball rolling for JNC8. The last update, JNC7, was back in 2003. However, before they were done with developing these guidelines, NHLBI withdrew from the guideline development and delegated it. The JNC8 panel decided to pursue publication independently, so this is not an official NHLBI sanctioned report. So if you care about these things, it's really not JNC8. What it is a report by the panel members appointed to JNC8, for whatever that's worth. In developing these guidelines, they asked 3 questions. First, in adults with hypertension, does initiating antihypertensive pharmacologic therapy at specific blood pressure thresholds improve outcomes? Second, in adults with hypertension, does treatment with antihypertensive pharmacologic therapy to a specified blood pressure goal lead to improvements in health outcomes? And third, in adults with hypertension, do various antihypertensive drugs or drug classes differ in comparative benefits and harms on specific health outcomes? So they asked these questions for several different patient groups. And they also considered the answers based on different levels of recommendation. Level A is a strong recommendation. There's a high certainty based on the evidence that the net benefit is substantial. Level B was a moderate recommendation, moderate certainty based on the evidence that the net benefit is moderate to substantial, or there's a high certainty that the net benefit is moderate. So either they're moderately sure the stuff is great, or they're really sure the stuff is moderate. C is a weak recommendation, at least moderate certainty that there's some small benefit. D is a recommendation against. E is for expert opinion. This is going to be an important one, you'll see in a minute. That means there's insufficient evidence or evidence is unclear or conflicting, but this is what the committee recommends. N is for no recommendation or against. All said and done, they came out with 9 recommendations. 2 of these recommendations were rated strong, 2 were rated moderate, 1 was rated weak, and 5 were rated expert opinion. This is a little bit surprising. Over half of them, they still had to relegate to expert opinion. They set out hoping to find strong evidence from randomized controlled trials of what to do here, but they really only had strong evidence for 2 of them, moderate for another 2. Here we jump into them. Recommendation 1. We'll go through all 9 of them. This is the longest one here. Recommendation 1 is that blood pressure should be less than 150/90 for patients 60 and older. This is a marked difference from JNC7. That called for a blood pressure of 140/90. They had a corollary recommendation with this one. They said if patients 60 and older are being treated and their systolic blood pressure is less than 140, there's no need to adjust the treatment if it's well tolerated. In other words, in the olden days, they recommended blood pressure below 140, systolic below 140. Now it's 150. They're saying if the patient's already below 140 and they're tolerating their treatment, you don't have to down dose their drugs to get their blood pressure up a little bit. You can keep them where they're at. Recommendation 2, diastolic blood pressure should be below 90 for patients younger than 60. That is a strong recommendation for patients 30 to 59, expert recommendation for patients 80 to 29. That is, there's very good evidence for this middle-aged, if you will, 30 to 59-year-old patients, but not as much evidence for younger adult patients, 18 to 29. Recommendation 3 is that systolic blood pressure should be below 140 for patients younger than 60. So for patients younger than 60, they're saying 140/90. Older than 60, 150/90. Recommendation 4, blood pressure should be below 140/90 for patients with chronic kidney disease. This is also an expert opinion. Recommendation 5, blood pressure should be below 140/90 for diabetic patients. Another expert opinion. Recommendation number 6 is that in non-black patients, initial antihypertensive therapy should start with a thiazide type diuretic or a calcium channel blocker or an ACE inhibitor or an ARB. That is, ACE inhibitor is angiotensin converting enzyme inhibitor. ARB is angiotensin receptor blocker. This also denotes a difference from JNC7. JNC7 recommended thiazides as first-line treatment, period. Start with thiazide. Now they're saying start with any of these 4 drugs: thiazide, calcium channel blocker, ACE, or ARB. Also, another change from JNC7, beta blockers were removed from first-line therapy. This is quite a departure. There was a time back in the olden days when propranolol was the most heavily purchased drug in the world, and now they're not recommending using it in blood pressure unless you have to get to a 3rd, 4th, 5th agent. Recommendation 7 was specifically for black patients. They should be started with thiazides or calcium channel blockers, not with ACEs or ARBs. This is moderate evidence, generally weak evidence for diabetics. And then recommendation 8, patients with chronic kidney disease should receive an ACE inhibitor or an ARB as an initial or an add-on treatment. That is a moderate evidence. And recommendation 9, the last one, is this: if blood pressure is not controlled within 1 month, doses should be increased or a second medication from the first-line group should be added. If you're still having a problem after a second month, you do the same thing again: increase or add a 3rd drug. ACE inhibitors and ARBs should not be used together. If goal blood pressure cannot be reached using only the drugs in recommendation 6, then antihypertensive drugs from other classes can be used. This is an expert recommendation. Antihypertensive drugs from other classes may include beta blockers, might also include alpha blockers, and there are a few other ones we don't think about so much anymore, but those are the two big groups that haven't been mentioned yet. Now when you look at this, there was one paper that came out with an estimate of how many patients would be affected by this, and what they said was that if you consider patients, adult patients 18 to 59, JNC7 applied to 20.3% of adults, JNC8 applies to 19.2% of these younger adults. That's a 0.9% reduction in patients that should be treated according to JNC8 versus 7. If you look at older patients, 68.9% of adults over 60 should have been treated under JNC7, 61.2% under JNC8. This report is not without controversy. Not everyone agrees with it. And it's important to point out these are guidelines. It's not, as they said in the Pirates of the Caribbean, it's not a code, it's guidelines. You don't have to follow it, but these are their guidelines. It streamlines therapy a little bit. It makes it a little bit simpler. And there are some patients that in the past, if you're following these, you would have treated, specifically if their blood pressure was in the 140s. Now they're saying you can wait until it's in the 150s. And that's it for the hypertension guidelines. The last topic we'll discuss today are the new lipid guidelines. Once again, it's a mouthful. The 2013 ACC/AHA guideline on the treatment of blood cholesterol to reduce atherosclerotic cardiovascular risk in adults. A report of the American College of Cardiology, American Heart Association Task Force on the Practice Guidelines. This was published in Circulation online in November of 2013. The goal of these new guidelines is to reduce atherosclerotic cardiovascular disease, or ASCVD. We're trying to reduce events associated with that phenomenon. Now, a healthy lifestyle, sadly for all of us, healthy lifestyle remains a foundation of ASCVD prevention. We're supposed to eat right and we're supposed to exercise. Beyond that, they also looked at drugs, and what they really try to do is look at randomized controlled trials to see what drugs and doses and treatment regimens have been documented to improve mortality and decrease disease. What they found was there's really no evidence from randomized controlled trials to support the treatment to a specific goal. In other words, what we've thought in the past is we wanted to reduce the LDL to 110 or to 80 or whatever. What they said was there's really no evidence that saves lives. The evidence we have are studies that said we have patients with high cholesterol, we're treating them with this drug at this dose, and here's what happened. And frankly, they couldn't find any evidence on some of the other drugs that aren't statins. That is to say, the statins are still involved here, but there's no recommendation for fibrates, there's no recommendation for fish oil, for niacin. They're kind of out of the loop here, and it's because while we know what they do to LDL or to HDL or to triglycerides, we don't really know when they're added to statins. We don't really know how they affect mortality, which is to say we don't have any proof that they do affect mortality. So they're not really involved in this thing. The focus is therefore to identify and treat patients who are most likely to gain benefit from statin therapy. And these new guidelines definitely simplify treatment. It's actually quite simple. The largest difference from the previous guidelines, the biggest difference, is they do not recommend treating to goal levels. You don't have an LDL goal you're shooting for or an HDL goal you're shooting for. You're just shooting to treat the right patient and treat them with the right dose of the right drug. And here's what they did. They broke down statin groups into actually 3 groups, but only 2 of them count here, so that's the only ones I have. They have high intensity, moderate intensity, and low intensity. There's no recommendation to use low intensity, so I don't even have those doses on here. For high intensity statin treatment though, they said this would be atorvastatin or Lipitor 80 milligrams and rosuvastatin or Kester 20 milligrams. As a lot of you know, atorvastatin did go off patent last year, and it's now a fairly inexpensive drug. Kester is still a trade name drug. They still advertise the heck out of it. They have really irritating bowling commercials right now. And it's still quite expensive. Again, atorvastatin 80 milligrams or rosuvastatin 20 milligrams. Then they have recommendations for moderate intensity treatment. That would be atorvastatin 10 milligrams, rosuvastatin 10, Simvastatin or Zocor, 20 to 40 milligrams. Pravastatin, 40. Lovastatin, that's the one that started it all. The first statin on the market, Mevacor, made $1 billion. For Merck Sharp Dome, nobody uses it anymore. But if you do, 40 milligrams is moderate intensity. Fluvastatin, 80 milligrams a day. Pitavastatin, the newest one on the market, is 2 to 4 milligrams. That's moderate intensity. Now, in doing this, they define clinical ASCVD. This would be acute patients with a history of acute coronary syndromes, myocardial infarction, stable or unstable angina, coronary revascularization, history of stroke or TIA, or peripheral arterial disease or revascularization. All of these patients are considered to have clinical atherosclerotic cardiovascular disease. So here are the guidelines. There are only 4 groups. It's actually fairly simple. If ASCVD is present, if their age is 75 years old or less, use high-intensity treatment. If their age is more than 75, or if they've been shown to be intolerant to high intensity, use moderate intensity. The second category is a primary elevation of LDL-C of 190 milligrams per deciliter or more. Those patients should receive high-intensity treatment. So they haven't shown any clinical disease yet, but their LDL is that high. Use high-intensity treatment, or use moderate intensity if they're not a candidate for high intensity. The third group is diabetics. Generally speaking, diabetics should receive moderate intensity treatment. However, if it's estimated that their 10-year ASCVD risk is 7.5% or greater, you can use high intensity, and I'll explain in a little minute what that risk means. So with both diabetics and this other group, estimated 10-year ASCVD risk is 7.5% or greater, it introduces this concept of an ASCVD risk. What is that, and how is that measured? There's a global risk assessment tool using pooled cohort equations where they assess patient risk of initial cardiovascular event, such as age, sex, race, total cholesterol, HDL, systolic blood pressure, whether the patient's on blood pressure lowering meds already, diabetes status, and smoking status. Those are the things they take into account. What they don't take into account are things such as family history of cardiovascular disease, triglycerides, waist circumference, BMI, lifestyle habits, and smoking history. They take into account whether you smoke now, but not whether you smoked in the past. This adds another element of controversy in here. Not everyone really understands or agrees with this global risk assessment tool. I will tell you it's easy to find it. There's an app for that. If you just go into the App Store and look for ASCVD Risk Estimator, you'll have it downloaded for free in about a minute. And it's quite easy to use. You plug in weight, sex, and these other factors, what's your systolic blood pressure, what's your total lipid level. Plug in these different things and it gives you your estimated cardiovascular risk, or ASCVD risk. The other 2 things I've added on here, actually 3, are 3 different websites that you can also utilize to get at this if you're not using a smartphone or an iPad or something like that. So that's a way to assess the risk of patients and figure out which level of statin they need to be on, or in fact if they need to be on a statin at all. And that wraps it up. Let's fill out the evaluation at the end. Thank you very much.